So I'll start out by talking about family history and genetics and give some context for a lot of the other things that we'll talk about today. The two main things that I want to do are to talk about the genetic causes of pancreatic cancer. That'll include a little bit of overview of basic genetics information, and then talk about how people can get genetic counseling and testing appointments and use that information for yourself and for your family. So starting out with some genetics background first. Always important to give context for why does genetic testing matter? So it can give information about a number of different things. It can tell a person if they have an increased risk to develop cancer, as well as whether their family members might have an increased risk. It can also explain why cancers have happened in the family before. When we have that kind of information, we can also implement early screening or risk reduction measures. If a person has had a diagnosis already, we can sometimes do targeted treatment options to be most effective in that treatment. And then most of the time, genetic testing provides reassurance that there is no single large hereditary explanation for why cancer has happened. Not everyone is eligible for genetic testing. So our main focus for today, of course, is going to be that anyone who has been diagnosed with pancreatic cancer themselves, or anyone who has a parent, sibling, or child who has a pancreatic cancer, those are the very straightforward ways in which a person can meet the criteria for genetic testing. I'm listing these up here briefly. I won't go over them in like point by point detail, but if you see a genetic counselor, they'll also be assessing if you have a family history of other types of cancer. And even if you have a relative that's further out, like a grandparent with pancreatic cancer, if there are other types of cancer in the family, you might still be eligible. Generally speaking, if I had to summarize all of these other bullets together, if there are many people in the family with cancer, especially common cancers, but happening at younger ages, or rare cancers, you might be eligible for genetic testing. So obviously we've got to go back to basics to talk about genetics. Most of the time genetic testing is a saliva or a blood sample, and this is just an easy way to get the DNA out of your cells. This is your body's instruction book. Genes are sections of the DNA, and you can think of them as being like words within the body's instruction book. Every gene has a particular job to do. And most of the time we inherit one copy of every gene from our mom and one from our dad. That's going to be true of the genes we talk about today. A mutation is a change to the gene where the body can't read that gene's instructions and do its job properly. And I'll talk in a little bit more detail about what it means when a gene normally has instructions to help protect from cancer and a mutation happens in that kind of gene. A term you'll also see me use is pathogenic germline variant. This is the more proper term, but mutation is certainly easier to say. And then to give you a few examples, there are many different ways mutations can occur, but common ones are a spelling error. If there's supposed to be a T and it's replaced with a C, just like a typo in a word, or missing or extra pieces of genetic information. So there's an example here of a deletion. That word germline in the pathogenic germline variant part means that this is genetic material that's inherited from parents and can be passed on to children. And one other term that we'll use throughout the day today is multi-gene panel. So all this means is that we can look at many different genes with one saliva or blood test. When we think about how these gene mutations are inherited if they're present, if you have a parent who has one cancer gene mutation, and this person may or may not have cancer themselves, every time that person has a child, there's a 50% chance to pass that mutation on, but also a 50% chance not to. If you don't have a mutation, you can't pass it on. There are some exceptions to this type of inheritance, but most genes that we'll talk about work this way. And one thing that is often sort of a misconception is that men or women can have mutations and they can pass them to their sons or their daughters. So getting into the specifics of what happens when a gene is supposed to help protect from cancer and it doesn't work properly. We're going to use the pancreas as an example for today, pretty obviously. And if we're going to zoom in and think for a second about a single pancreatic cell, remembering that this cell contains DNA and genes. Most of the time, cancer protection genes work in different parts of the cell to help regulate that cell's growth, to help prevent it from growing out of control and becoming a cancer or tumor. So when a gene is spelled properly, damage does occur to our cells as we age and as we go through normal bodily processes. But most of the time, these genes can help intervene and stop a damaged cell from growing out of control. Cancer can still happen, even if a person has no genetic mutations. But when it happens, it just means that it's not due to a single genetic predisposition. And there are many different factors that cause cancer to happen sporadically, the biggest risk factor being age. But when a person has a genetic mutation, it's inherited from their parent, it's present in every cell of their body. And then some cells have an increased risk to develop cancer. So if damage occurs, the mutated gene can't help protect that area of the body and it can't control the cell growth. So people who have cancer gene mutations are more likely to develop a cancer. It's not 100%, it's just more likely than average. And the exact type of cancer that a person is at risk for varies from gene to gene. So I'll give some examples of that in a second. When we know that a person has a genetic mutation, we also want to offer them different care to help detect or prevent cancer as early as possible. There are specific guidelines that are different for each gene and for cancer type, but for right now, I'll give a general overview of different things that might be recommended across the board. So generally speaking, the tools we have to help people if we know they have a mutation involve doing some type of scan or imaging of whatever area of the body we're concerned about. Some of these are things that a person might have anyway, like a colonoscopy or a mammogram, but we might start them at a younger age or do them more frequently in a person who has a mutation. There are also times where we have blood marker tests that can tell us how certain organs are functioning and if a tumor might be developing. And then these last two boxes generally refer to a small number of genes where a person might have a very high risk for breast, colon, or ovarian cancer. And there are times where we have medications or sometimes risk-reducing surgeries to help prevent cancer from happening. So I'll give a small example of a pancreas-specific screening protocol, and then other speakers today will go into more detail of that. So we'll get to that in a couple of slides. When we think about how often is pancreatic cancer due to something genetic, most of the time, pancreatic cancer is sporadic. About 80% of the time, there is no underlying genetic cause, and there's nothing in the family history that makes us think that there might be something genetic going on. So most of the time, if there is just one diagnosis in the family, especially at an older age, it's going to be sporadic. About 10% of the time when we do a blood or saliva test, we can find an underlying genetic explanation for why cancer happened. So we'll go through that in just a bit. When we do multi-gene testing, it's because we are looking at not just genes that are associated with all the known causes of pancreatic cancer, but often many cancer types, just to be broad, just to catch anything that might be there. And then this last piece of the pie is a very particular set of circumstances where we see multiple people in a family who have pancreatic cancer, but when we do genetic testing, it comes back negative, where we do not find any identifiable mutations. And because this is a rare type of cancer, the odds that you would have multiple diagnoses and close relatives in the same part of the family are pretty low, and we think that there might be missing or undiscovered genetic risk factors here that we just can't test for yet, but there certainly are tests in development to be able to fill in this missing piece of the pie. When there are mutations that we can find in genes associated with pancreatic cancer, roughly half of the time, they're due to the BRCA1 or BRCA2 genes, which are commonly referred to as the BRCA genes, but these are not the only genes that are associated with pancreatic cancer or other types of cancer. Roughly half of the time when we find a mutation, it's in another gene. So this is a busy table, but it does give an overview of the different syndromes and different genes we know of that are associated with pancreatic cancer. The main takeaways here are that all of these genes work in the pancreas, but they work in other places too. It's quite common for genes that help to protect the pancreas to also help to protect the breasts and ovaries in women, or sometimes the prostate in men. I listed the lifetime risks for pancreatic cancer down the middle here. So this specifically means the risk for a person to develop pancreatic cancer between birth and age 80. And I'll have a visual representation of this on the next slide. One thing to note for now is that all of these conditions that have stars next to them are conditions that are more common than the others listed on this table. And you can see that the more common conditions tend to have increased but lower pancreatic cancer risks than rarer conditions. This is just an easier way to see that not all of these genes are created equal, and even with a mutation, it does not mean that pancreatic cancer or other cancer types are guaranteed to happen. So this is just specific to pancreatic cancer. It doesn't show any of the risks for other cancers associated with these genes. And to put things in context, the very first bar here shows that everyone has a risk for pancreatic cancer, even if they have no family history of this condition and no genetic mutations. The second bar is that condition where there are people with multiple relatives but no identifiable mutation. And then you can see that genes that are more common have increased but lower risks overall, as I mentioned. So when we know that a person has a mutation in one of these genes, or if they meet that familial pancreatic cancer criteria with multiple relatives, we do screening for them. And the age at which screening starts varies. Often it's age 50 or 10 years earlier than the earliest diagnosis in the family, whichever one of those ages comes first. Very briefly speaking, pancreatic cancer screening at present often involves having an MRI of the pancreas or a specialized procedure called an endoscopic ultrasound, one or the other every year. And there are several blood tests that often are paired together with these imaging types in order to get input on not just how does the pancreas look, but how is the pancreas working. Additionally, if a person has a pancreatic cancer diagnosis, knowing if they have a mutation might have implications for their treatment plans. There's been a universal recommendation for every patient with pancreatic cancer to have genetic testing since late 2018 or so. And that's because if a person has a mutation in the BRCA1, BRCA2, or PALB2 genes, then they might be recommended to have particular types of chemotherapy that are platinum-based and might be more effective for these mutation carriers. And for patients that have a condition called Lynch syndrome, which can be caused by mutations in one of several different genes, there is a specific type of immunotherapy that might be given at a particular point in their treatment if other types of treatment have not been effective to date. So with that background on the genetics of pancreatic cancer, how can you take this information and use it for yourself and your family? The way to get a referral for genetic counseling, which just means seeing a provider like myself, whose role is to order and interpret genetic testing in the context of family history, is to talk to your doctor about it, like most referrals. Doctors that are often very familiar with genetic counseling include primary care doctors, gynecologists, gastroenterologists, sometimes dermatologists, but really most doctors should be able to make a referral to a cancer genetic counselor. You can also do a self-referral. So I've listed the scheduling line here. You can also email me and I'll help connect you to our schedulers. And if you are not local to the New York City area, I've listed a website and then a couple of screenshots that should help you navigate to find a cancer genetic counselor close to where you are. And there are often in-person or telemedicine options available. When a person is scheduled to see a genetic counselor and you're thinking about what information you need, it does take a little bit more preparation than the average doctor's appointment, but we talked with people who are adopted and who don't know anything at all. So any information you can gather about your family is going to be helpful, and don't stress if you can't get every tiny detail. In general, a genetic counselor is going to be drawing out a family tree or pedigree, and that includes information on close relatives, which are listed here. We don't usually go out further than that. The main things that I want to know whenever I'm drawing a family tree is how old are your relatives, or how old were they when they passed away? Who had cancer and who did not? What type of cancer and how old were they when that happened? All of those ages can be rough ballparks. Generally, I'm happy if I can say younger or older than 50, and if it's truly not known, that's okay too. A really important thing is who has had genetic testing before. And this can be if you've had genetic testing in the past to see if maybe we need to update that testing because there have been new gene discoveries and new technologies over time. Or have there been other people in the family that have been tested? Maybe their test result has been informative for you, and we might not need to test you if a better person to test in the family has already had that. Generally, we like to test people who have had cancer themselves, because if we're going to find a genetic mutation, we're most likely to find it in someone who has actually had a cancer diagnosis. So getting a copy of report from your relatives that have had testing is really helpful, even if that report is negative. That's information that might save you from having a genetic test. When genetic testing is indicated, usually you'll meet with a genetic counselor or a doctor who has expertise in genetics. There are different appointment types available. They'll go over that personal and or family history of cancer, including the pedigree, and then talk about, is genetic testing appropriate in this scenario? If so, what type of test should we order? What are the possible outcomes and what are the possible costs? Most of the time, genetic testing is covered by insurance, especially if a person's family history meets some of those checkbox criteria that I listed earlier. And the costs for this out of pocket have come down significantly over time. Back in the 90s, early 2000s, it used to cost about $4,000 to have a genetic test if insurance didn't cover it. But now, most of the time, it's $250 at most, and many patients have it covered in full. Then if a person wants to proceed with testing, they give a blood or saliva sample. It's sent to the lab. The results are usually back in about 2 to 3 weeks. And then a genetic counselor goes over the result with you and interprets it specifically in the context of you and your family. I'll go through a little bit of information about the possible test results. So first, sometimes we do find genetic mutations, and that means that there is an increased risk to develop cancer. The exact cancer type that a person is at risk for, and then the screening and risk reduction options are going to vary from gene to gene. So the genetic counselor would go over that with you and then would make referrals to the appropriate specialists. If someone does have a mutation, then your closest relatives, parents, siblings, and kids each have a 50% chance to inherit or not inherit any mutation found in you. And other relatives are also at risk depending on their degree of relation to you. Most of the time we get negative test results. And that means that there's no one single genetic reason why a person might be at a significantly increased risk for cancer, but they might still have slightly higher risks than the average person if they have a family history. So most of the time we're able to recommend that if a person has a negative test result that they follow the general population cancer screening recommendations, but we do sometimes tailor that and recommend extra screening if a person has a family history, say, of pancreatic or breast cancer. Sometimes they do still have earlier screening or extra screening, with the example listed there for people that meet that familial pancreatic cancer criteria. If a person is negative, they can't pass a mutation on to their children, but it's always possible that the family history of cancer may be due to a mutation that they did not inherit and that other people in the family might be at risk for. So if a person gets a negative result, I do often talk to them about whether or not genetic testing might still be indicated for people like their sisters or parents or cousins. And then finally, sometimes we get an uncertain result. This is not a genetic mutation. It's a spelling change to the sequence of the gene that has an unknown impact on the gene function. The way I often explain this is that if DNA is your body's instruction book and genes are words in your instruction book, a variant of uncertain significance is comparable to how there can be American and British spellings of the same English word. It's a change, but it's a change that the body might still be able to understand because it's so close to the normal variant. So 97% of the time, these types of changes get reclassified to be benign. They're very common. We treat them the same as a negative result until we learn more. So we look to the family history to guide us on whether or not any extra screening is recommended. And we do not recommend testing for other relatives on the basis of a VUS alone, but might still recommend it based on the family history. So wrapping all of that up, most of the time pancreatic cancer does not have a single genetic cause, but about 10% of the time it does. If you or one of your relatives has a diagnosis of pancreatic cancer, genetic testing is certainly appropriate. Most of the time, testing is covered, and there are 3 possible outcomes. If we find a mutation, it does not mean that cancer will happen, and it means that we can change a person's medical care to try our best to help keep them safe and healthy. And then we can test other people for the mutation so we know within the family the breadth of who needs to be screened. And a negative or uncertain result is treated the same. It can provide reassurance that we might not need to do screening if there's no significantly increased risk, or we might still screen if the family history is concerning enough, and testing might still be indicated for other relatives. So that is everything for your introduction today. Thank you for your time, and there will be some time to ask me questions, and you can always email me.
My role in this process is really to try to help patients understand what is the best approach to screening, how to go about screening, and the way we sort of evaluate patients is that we first try to assess what is their risk and whether screening should be indicated. So why is that even an important conversation? So this is a slide about pancreatic cancer. Some variation of this you will see many times during the day today. And one important takeaway message from the right side of this slide which is a survival curve, is that when we diagnose pancreatic cancer at an early stage, which is stage 1, so this is somebody who has a small lesion, typically less than 2 centimeters, and no evidence of the disease having spread across the outside of the pancreas, the ability to cure a patient with that type of pancreatic cancer is our best chance. It's not to say that, and you'll hear about some advances, that there aren't much better outcomes. This is actually an old survival curve, old meaning before some of the treatments that are now available have been introduced. But the difference between early stage pancreatic cancer and later stage pancreatic cancer remains. So the reason we do screening and the reason we try to do early detection is that when we catch it that early, truly the survival is better. This is another sort of bird's eye view of this, which is a survival curve looking at the survival of patients with pancreatic cancer who are found to have a pancreatic cancer in the context of a screening program. So this is these are programs that exist across the country. We have one, many institutions have one where patients, and we'll talk about these patients, but the ones that Shannon introduced earlier are enrolled in this program and are regularly screened. And if they are found to have a pancreatic cancer in the context of the screening program, the likelihood of curing cancer is much greater. That is definitely the glass half full kind of view of this graph. Unfortunately, the glass half empty view of this graph is that even in a screening program, we unfortunately still encounter patients who, in between their different screening modalities, develop advanced cancer, and we're unable to cure them. So obviously, there's still a lot more to do in this area. And we're definitely not perfect at being able to catch every cancer that we screen for early enough to be able to cure patients. So this is a little bit about the biology of pancreatic cancer. Pancreatic cancer can develop from essentially on 2 different pathways, and you will hear about some of these things in different talks and different contexts. But the majority of pancreatic cancer, about 85% of it, develops from pancreatic ductal cells through a transformation predominantly driven by genetic changes in the pancreatic tissue, but as we heard, also sometimes driven by germline or inherited genetic changes. And these cancers develop into something called pancreatic ductal adenocarcinoma. And when you hear about pancreatic cancer, this is dominantly what patients are diagnosed with. A smaller minority, but an important minority, develop from pancreatic cystic lesions, predominantly something called mucinous cystic lesions, and they develop a pancreatic mucinous adenocarcinoma. Once these patients have developed cancer, where this came from doesn't make a very significant difference in the treatment of cancer. But there's a big difference between what we can see in our, at this point, before these patients develop cancer, because pancreatic cystic lesions, which are little cysts in the pancreas, are something that we now know how to pick up on different imaging studies. Unfortunately, for the so-called precursors or precancer lesions, for the majority entity, pancreatic ductal adenocarcinoma, we are not able to see a lesion before a small focus of cancer develops. So what is sort of the challenge and the goals of screening in light of these sort of 2 different biologies? So for the majority of pancreatic cancer screening, our goal is to, for the majority, meaning that the majority of pancreatic cancer develops through this process of eventually developing a small mass from a ductal cell and then unfortunately growing and spreading fast. For most of those patients, our goal today, and this hopefully will change, but our goal today is to be able to catch and detect a very, very small cancer, typically a less than 1 centimeter cancer, which again, referring to the first slide, means that we can cure those patients by potentially removing those small foci of cancer. It's a little bit different goal with pancreatic cystic lesions. When you find a pancreatic cyst, because we can see this and because we know that these are common, a minority will develop cancer, And but we have the ability to see this precursor lesion. Our goal here is actually in a way to prevent the development of cancer. So to identify patients who have a cyst, identify among the patients who have a cyst, the small minority of patients who are really at risk for growing that cyst into a cancerous cyst, and intervene or offer an intervention before cancer develops. Why do we sort of talk so much about the challenges and the difficulties of screening for pancreatic cancer? So one of the reasons for that is that it is ultimately a rare cancer. It is a devastating cancer, but it is a rare cancer. It affects somewhere between 12 to 14, 15 people per 100,000. And this is sort of a little bit of a back of the envelope kind of calculation of the difficulty of screening for such a rare cancer. What happens is that if you were to screen every individual with that risk with that population risk, in other words, everyone in the population, the same way as we screen for breast cancer or colon cancer or cervical cancer, which are more common cancers, one of the issues we would encounter is that even with a near perfect screening test, and unfortunately we don't have a near perfect screening test, what is sort of calculated here is a test that has a specificity of 100% and a sensitivity of 98 or 99%. So that means it catches every cancer and only falsely diagnoses 1% of the cancers. But if the frequency of finding cancer in the population is so rare, that very rare sort of false positive result turns into an enormous number. And that means that you're potentially doing actually more harm. Potentially you are going to offer patients with a rare disease for a false positive result, some sort of intervention that has the potential to cause harm. So when we think about pancreatic cancer, I think the community, the science suggests that we should really be focusing on screening patients who are at an elevated risk for pancreatic cancer. These individuals are called high-risk individuals. And the goal is that individual at the time that they begin screening has somewhere around at least a 5 to 10-fold higher risk than the average population. At that point, we believe that the cost benefit, and cost is the wrong word here, but the risk benefit of screening favors the benefit, even though we know that there will be false positive results. It is a fewer number of patients that will be affected by false positive results. So how do you find these high-risk individuals? This concept is largely true for many cancer screenings. At the beginning of lung cancer screening, and even today, we screen we screen smokers differently than we screen non-smokers because we want a population where there is an elevated risk at baseline. Unfortunately, or fortunately, for pancreatic cancer, there isn't such a clear either environmental or sort of readily identifiable risk factor from the patient's sort of history or demographics that help us identify patients at risk for pancreatic cancer. And as Shannon already introduced, one area or two areas where there is a significant elevated risk is the presence of a germline mutation or a family history of pancreatic cancer. So these are the patients who are considered high-risk individuals and who are then quote unquote eligible for pancreatic cancer screening because of the fact that the risk and the benefit of screening then favors the benefit of screening. So who are these individuals and what is who are these people and what is their risk? So this is a slide, actually, I believe it is a slide originally drawn up by Shannon, and a variation of this was presented by her, but this lists, again, the same mutations that she talked about and sort of the magnitude of risk associated with carrying these mutations or having a family history of pancreatic cancer. And again, there's a variation in this. She already mentioned that some of these that thankfully are the lower risk mutations like BRCA1 and BRCA2 are somewhat lower risk of developing pancreatic cancer. At the bottom of the slide, there are some relatively rare mutations that are associated with certain syndromes that carry a somewhat higher risk of pancreatic cancer. And this dictates when and how we screen patients. So depending on what the risk of the mutation that one carries, it determines when we start screening. The first two mutations are associated with two syndromes. One is the top one, the STK11 gene, is associated with a syndrome called Peutz-Jeghers syndrome. And the second one is the familial atypical melanoma and mole syndrome, or FAM syndrome, that are carry a very significant risk of pancreatic cancer. And unfortunately, these patients develop sometimes cancer at an early age, so screening starts at a young age. For the other mutations and for the family history, we generally recommend that patients start screening at the age of 50, or if in their family there is an early onset of this cancer, then they start screening at a younger age than their affected relative, 10 years younger than the affected relative. So you've seen also a similar slide to this. So what screening do we do and how? So as it was mentioned, imaging is really the dominant modality to screen for pancreatic cancer. We typically do some kind of a complement of magnetic resonance imaging and endoscopic ultrasound. Magnetic resonance imaging really has evolved as a very sensitive way and a very efficient way to image the pancreas. It does not require radiation. It's not a radiation-based test. So in many ways, I often tell my patients that it is kind of a harmless test in the sense that it has no real direct effect on the body, such as radiation or other side effects. Endoscopic ultrasound is a procedure. It's a procedure that I perform routinely, and many of my colleagues here perform routinely. The advantage of it is that it gives a slightly different and very close view of the pancreatic parenchyma and allows us to complement the imaging of the pancreas, complement the MRI imaging of the pancreas. And then I think biomarkers are very, very slowly becoming an important part of this algorithm. I think we all hope they will take a much greater role in screening for pancreatic cancer, because it's certainly much easier to draw a tube of blood than to undergo a 45-minute MRI or a procedure such as an endoscopic ultrasound. I don't think we're quite there yet, but it is certainly evolving as a modality. So what do we actually find when we screen patients? And I think this is an important thing that we have to think about, because I think that's ultimately what patients and everyone cares about. So about half of the time, probably maybe even a little more than half of the time, we find a normal pancreas, which is great news. It's a very reassuring finding. It means that really at that point, there is no abnormality that requires additional action. But it is important to recognize that it still means that continued screening, if you were in one of these high-risk categories, is indicated and necessary, and that screening has to be regular. This is unfortunately a fast-growing and fast-developing cancer, and so continued screening is necessary. What is recommended for that continued screening or surveillance? So we repeat these tests, MRIs on endoscopic ultrasound, and to some extent blood tests, on a regular basis. How intensely we repeat it or how frequently is driven again by the risk, by the underlying risk of developing cancer. For again, some of the higher risk genetic mutations, they're repeated more frequently. And we kind of alternate the two modalities, MRI and endoscopic ultrasound. For some of the lower risk mutations, they're repeated somewhat less frequently on an annual basis. What is the second most common finding? So the second most common finding ends up being a cystic lesion in the pancreas. And we'll come to talk about this in a minute, of what do we do with this? Because this is ultimately the most common finding. And it is in this day and age, at least at this institution, I suspect that nearly all institutions across the country, when you undergo an MRI, within 2 to 3 hours of getting that MRI done on your electronic health record that you have full access to as a patient, the result pops up. And about half of the patients, a little less than half, 30 to 50% of the patients will read on that first MRI that was done for pancreatic cancer screening that you have a 1.9 centimeter pancreatic cyst. And without knowing what this is and what to expect to do with it, this is a very, very sort of obviously anxiety-provoking news, because you're screening for pancreatic cancer and it reads a pancreatic neoplasm in the pancreas. So what does that really mean? But before we sort of go into that, I will just say that the other sort of less likely findings are that we find sort of changes of equivocal significance, and this is the hardest. These we really carefully review in our multidisciplinary board, and those cases are very specifically individualized. And in about 0.5 to 1% of screening exams, we detect an early cancer, and these are the cancers that are then referred for hopefully a curative intent resection, where we can actually remove this small cancer and cure the patient. So back to cysts. What do we do with this cyst, and what is the significance of it? So I put this slide up there. This is not specifically for our high-risk patients. This is for the average population. Cysts are incredibly common in the pancreas. The number of cysts we diagnose is growing, whether it's growing because we're imaging patients more, or whether it's growing because there are more cysts forming for environmental or other reasons. That's to be seen. It does seem like the general population prevalence of this is rising, but they are very, very common. And if they are this common, and you saw how rare pancreatic cancer is, I always put this in perspective that the risk of developing cancer from a pancreatic cyst has to be very, very low. When we see this, we immediately ask, is this a cyst that is potentially cancerous? That's a small minority of cysts. Is it a cyst that is potentially precancerous, or is it a cyst that's completely benign? How do we sort of determine this? So we always start with the imaging, and sometimes the imaging just tells us everything. If there are some characteristic features of cystic lesions that tell us that this is a benign cyst, let's say a serous adenoma, a picture of it is shown on the bottom left, which is this kind of star-shaped cystic lesion. This is a serous adenoma. If this is found in the pancreas of a patient screened for pancreatic cancer, this has no significance for their risk of pancreatic cancer. This is a benign lesion. And sometimes it's not so obvious. So then we sort of go through, and this is like a little bit of a rainbow slide of what are their risk factors. Do we classify this into a high-risk cyst, a worrisome cyst, or a low-risk cyst? How do we do that? So this is where we then rely on sort of endoscopic evaluation and further sampling of the cyst to try to find out what is the risk of a pancreatic cyst becoming cancerous or potentially being a high-risk precancerous cyst. And with this evaluation, in about 95% of the time, we can make an accurate assessment of, again, classifying them as a low-risk cyst. So that becomes just something that needs to be watched. These patients have a very low risk of harboring malignancy at that moment in time. And regular surveillance, again, with the same imaging modalities such as MRI or endoscopic ultrasound, should be sufficient to detect any change in these cysts to sort of raise an alarm bell. Versus if they fall into a high-risk category, a high-risk cystic lesion, based on this evaluation or the imaging evaluation, those cysts are patients where we worry that either they harbor a malignancy at the time of diagnosis, or they have a very high risk of developing malignancy in a short period. That high risk is around 20 to 30%. And at that point, we believe that surgical resection of a pancreatic cyst is indicated as an attempt to cure the patient of this neoplasm and help hopefully prevent the development of actually pancreatic cancer. So at the end of the day, I'm a gastroenterologist and an endoscopist, and one of my sort of goals when I entered this field or hope was to be able to offer treatment for some of these precancerous lesions that don't necessarily require surgery. And thank God our surgical sort of expertise and abilities have really improved over the years. And surgery is much, much safer than it used to be when pancreatic surgery was first performed. But it still would be wonderful if we would be able to offer pancreatic cancer or pancreatic precursor, pre-malignancies treatment without needing to undergo surgery. That's what this little video in the middle is showing. This is an endoscopic way to essentially ablate or get rid of a cystic lesion. This is something that's still in its infancy. We are in a very select patient population. We offer this, but this is one of my patients who underwent this procedure, who on the left had this relatively large cystic lesion that for multiple reasons was felt to be a worrisome cyst, and underwent this procedure, which is really just the same endoscopic procedure that you do for a diagnostic test, underwent this procedure, and this procedure was able to ablate the majority of the cyst. And 6 months, and actually now we're like, I think 36 months after the procedure, the cyst has nearly disappeared and has not progressed. Does this mean that we have cured this patient from the risk of ever developing pancreatic cancer? I don't think we can say that, but I think it is a little bit of a hope. And again, as somebody who practices this, I think this is a little bit of a potential game changer in the management of premalignant lesions such as pancreatic cysts. And with that, I will summarize to say that I think pancreatic cancer can be detected early. When detected early, there is a chance that it can be cured. Close relatives of patients with pancreatic cancer should be screened. And Shannon emphasized this also in her talk, that if either you have a first-degree relative or you know of someone who has a first-degree relative, those patients now should be undergoing evaluation for potentially screening, starting with a genetic test. Individuals with certain genetic abnormalities should be screened. Cysts are very common findings. They're not necessarily alarming. The majority are benign, but should be evaluated carefully by a multidisciplinary team. Most cysts are benign, but finding the rare high-risk cysts offers an opportunity to actually prevent the development of pancreatic cancer. And perhaps looking into the future, one thing that we will potentially offer as a routine is non-surgical treatment for pancreatic cysts. Thank you very much.
Hi, I'm Brian Kaplan. I'm one of the other pancreas surgeons. Any questions from the audience after those two discussions? Yes.
Hi, Dr. Ganda and all of you. Does it make any difference where the pancreatic lesion is, whether it's the tail or the body or?
So in some ways, the answer is no, in the sense that from the standpoint of where the cancer developed and what is the sort of genetic risk, genetic predisposition to it, we haven't really found that there is major biological differences from that regard. In other ways, it actually probably does make a significant difference in the ability, and that's why I pointed to our surgical colleagues, to be able to remove and potentially cure the patient of the cancer. The risk of surgical interventions and surgical procedures, depending on where it is in the pancreas, are different. And interestingly, there are now sort of some signs that biologically cancers that develop in the tail of the pancreas versus in the head of the pancreas behave differently, have different one of the areas that's an active area of investigation, different microbial sort of composition, so different bacteria that may be present in the cancer and drive these. But I think the quick answer is that if you're asking from the perspective, does it matter whether your family member had a cancer in one part or another of the pancreas, the answer is no. For an individual with pancreatic cancer, it makes a significant difference in terms of treatment.
Yeah, I can follow up on that a little bit too. In general, tumors that grow in the head of the pancreas, so would be treated with a Whipple operation. We tend to do many more Whipples than distal pancreatectomies because they often cause jaundice, which actually is an early warning sign. And so the ones in the tail of the pancreas, when they cause symptoms, which is usually pain or weight loss or something like that, they're usually more advanced. So biologically, as Dr. Ganda was pointing out, there's probably no difference or minimal difference, even in those studies looking at the microbiome. There's lead time bias in that we catch the ones in the head earlier. So there's probably very minimal biological difference, but in general, it's the ones in the head that we catch earlier. It is a bigger operation to remove them, but once removed, the prognosis is the same stage for stage. I had a question for both. It was both wonderful talks and great review in the genetics and screening. I just was wondering if you, either one of you could talk a little bit about what is known about modifiable risk factors, smoking, obesity, those types of things, and the interplay of those things on genetics. Like, so pancreatic cancer is always a genetic disease, like all cancers are, but the difference in, inherited germline risk versus environmental risk as such as mutagens.
I don't have as detailed of an answer as you would like. So it does make sense to think that in an ideal world, we would have stratified risks for people that have mutations with or without smoking, or mutations with or without alcohol use. That type of data doesn't exist for right now. I often get patients who ask me, if I have a mutation, is there a certain diet that I should follow? Is there a certain exercise regimen I should do? And the answer is nothing particularly exciting or different from what people have been told their whole lives in terms of living a healthy lifestyle, maintaining a healthy weight, don't smoke, alcohol consumption in moderation. That's about the extent of what I can say with it, that there's probably some degree of interplay between germline mutations and environmental factors. I think that the germline risk is often so great that the environmental factors are not going to make a difference in whether or not we screen someone. But that's about all that I can comment from a germline genetic standpoint.
No, I think I agree with that. Unfortunately, we don't have really strong data whether sort of a synergy of risk exists. I think probably smoking is the one thing that I stress the most in patients with a genetic predisposition to pancreatic cancer. And there's a little bit of data suggesting that if you are a smoker and carry a genetic mutation, then the risk of developing cancer is a tad bit higher than in the population who are not smokers. But as you saw from the slide, some of these risk factors are actually some of these modifiable risk factors, smoking, alcohol, etc., are actually relatively modest risk factors for pancreatic cancer. So it's very hard to prove that they would truly increase the risk of, let's say, a BRCA2 carrier patient over the risk that they carry based on the mutation. Having said that, as I said, I think smoking is the one thing that I feel that. I mean, obviously, we talk about smoking cessation for all of our patients, but when I see a patient who carries a genetic mutation and they're an active smoker, it's the one time when I really pause and take 15 minutes to stress the importance of that. And I think that there is, again, some data to suggest that that's true.
There's tons of great questions online. I'll start with one. Can circulating tumor DNA lead to early detection of pancreatic cancer?
Oh, that is a great question, and I think the can is the key to this answer. I think it can, and I think at one point it will for sure. I think there's been a lot of really nice work trying to define the role of this. It's not ready for prime time in the sense that I don't think that even commercially there is clear availability of using this, although I think it's pretty close. I think we will see that explode. Again, the false positive is, I think, what we worry a little bit about, and that's why it hasn't entered practice. But that is the future. I worry about this a little bit because if you have a blood-based test that suggests a risk for or let's say a concern for a presence of a pancreatic neoplasm, but there is no currently available parallel imaging correlate that shows a pancreatic cancer, you end up in a very difficult conundrum. You have this risk that is determined based on a blood test, which you cannot correlate with any finding. And I don't think we know yet what to do with those patients. It's certainly not strong enough data that those patients should undergo any sort of preventative intervention, but it is definitely the future. Circulating tumor cells and in general, blood-based biomarkers are definitely the way this will evolve.
I get questions about this from patients as well. The other thing too is that the circulating blood tests they can't tell you anything about a genetic mutation. But one other clarifying point is that the data on these tests at present, the detection rate, the good detection rates are for stage 3, stage 4 cancers. They don't have good sensitivity and sensitivity for stage 1, stage 2 cancers, in which case it's not better than the methods that we have. I agree that it's where the future is going, and I think that there will definitely be utility, especially for mutation carriers, but there's a reason it wasn't included yet in the different types of screening that are currently the standard of care.
Another very timely question, the role of AI in pancreatic. You read a lot about that.
I am not going to touch it.
Yeah, so I think AI is going to change the way we interpret everything in medicine. But in relation to this, we are already sort of looking at and trying to implement ways that AI will change our ability to analyze imaging data. So one of the things that we have that has been recognized is that the imaging data that you get of the pancreas and what we're looking for on an MRI scan has evolved and has gotten much better. But shockingly, when you feed it into AI, and this is like feed it into a black box, sometimes it spits out sort of associations or markers on an imaging study that we have not even thought of, something to do with tissue imaging, or the way tissue appears on an MRI that's around the pancreas, or maybe even distant from the pancreas, or the way the bone images. So AI is changing our way. I think the most immediate thing that it has an impact on is that AI is changing the way that we can use the imaging data that we have, and we can potentially really find new associations or new markers that can be very impactful in the early detection space.
I said I wasn't going to touch that. I lied. Sorry. I think that the best use I can think of for AI in genetics is for crunching the complex data to eventually identify some of those missing risk factors. I think that getting your genetic testing result delivered by a computer is probably not something that anyone would want. But in terms of like doing the drudgery work of figuring out those sort of complicated interactions and going through identifying smaller risk factors, which is harder to do and which is part of why it's not available, like full speed ahead, use AI for that.
Okay, another question we have is some patients are concerned that knowing the genetic information may lead to discrimination, their healthcare coverage being taken away. Can you comment on that?
Yeah, there is a federal law that's been around since 2008 called the Genetic Information Non-Discrimination Act. It is something that applies not to every single patient, but to the vast majority of patients. So essentially, the times where it doesn't apply are people that like work for very small companies and have insurance through those companies, some government employees, and then some like Native American insurance plans. But outside of that, GINA applies to almost everybody, and it covers several main things. GINA means that if there is some reason that you need to disclose your genetic mutation status to an employer, you cannot be fired or denied a new job based on that. It's also like, it's hard for me to think of circumstances where you would need to disclose that, other than perhaps if you were having a preventative surgery and needed to provide justification for that. But many people have surgeries for other reasons. So you can't lose your job, can't be denied a new job. Your health insurance can't be taken away or cost more just on the basis of a genetic mutation alone. So sometimes I have people who want their genetic testing report kept out of their medical record, which isn't really possible. I don't have a way to, as a healthcare provider, to order a test and keep it out of your record. And you also want that in your record because you want your insurance to cover the screening and preventative measures, and we need that justification. It is private and protected by HIPAA as well as, you know, other privacy laws. So doesn't impact healthcare. It also doesn't impact any pre-existing life insurance or long-term disability insurance policies. So when I talk with young people who might not have life insurance yet, I often tell them, get a policy in place if that is something that you want and something that you care about. You can answer honestly that you do not know if you have any genetic mutations because you haven't had this test done yet. And your parent status is something that will be reported in the family history, but it may not be passed on to you. So once a policy is in place, none of the information about a genetic test that you have done afterward is going to be passed on to that company. So an existing policy is protected.
Thank you. The other follow-up question is, you mentioned in your talk that siblings and parents, et cetera, should be screened. What about more distant relatives?
It
Like
depends.
cousins and?
Yeah, it depends. I mentioned briefly a designation called familial pancreatic cancer. So there are multiple different ways a family can have that label applied to them. Most of the time, in order to have screening, you need a mutation and a first or second degree relative, or you need to meet that familial pancreatic cancer criteria, and you need to have a first degree relative in that scenario. I think something that Dr. Ghana can comment on is that we certainly have patients that are interested in screening regardless. It's just less clear whether or not it might be covered by insurance if you don't fall into one of those categories. So.
No, I agree. And this comes up often. And, I have sort of a three-pronged approach to this. I think when somebody comes and asks about pancreatic cancer screening and their relative is not a first-degree relative, I think one of the things I always try to get a sense of is how big of a family they come from. I think that makes a major difference. If you have an uncle who had pancreatic cancer at the age of 70, but every family member on that side of the family has died, or you don't know their sort of health history, or died at a young age, then you don't know whether that's actually a very affected family because of the paucity of family members, or is it or is it truly one distant relative? On the other hand, I would interpret it very differently if, let's say, and we see patients often. I'm always sort of surprised, but it does happen very often. They'll come from very, very large families that you have, your mother or your father had 15 siblings, and out of the 15 siblings, one of them developed pancreatic cancer at the age of 80. So the risk there will be a little bit different. At the end of the day, as I said, screening for pancreatic cancer is imaging-based. MRI is a nearly harmless test. If once you understand that, and once you know that, that there are significant risks of false positive findings with these tests performed for very low risk individuals, I don't think it's unreasonable to consider screening, even if your family is of a lower risk family member or lower risk family. I think you just have to understand what is the true risk of screening, and we have to understand how well we understand your sort of familial risk.
Thank you for that very informative session. We'll move on to our next session.